Linnea, and my presentation is going to be on strokes. What is a stroke? A stroke is a neurological disorder characterized by a blockage of blood vessels in the brain. When blood flow is suddenly interrupted, the arteries clog, causing blood vessels to break and bleed. Without proper blood flow, oxygen cannot reach the brain tissue, which causes sudden cell death or necrosis. This is some quick brain anatomy. The frontal lobe is responsible for personality characteristics, decision making, movement, and speech. The parietal lobe is responsible for a person being able to identify objects, understand spatial relationships such as like proprioception, um, under, understanding where you are in space, language, interpreting pain and touch. The occipital lobe is mostly responsible for vision, and the temporal lobe being short term memory, speech, musical rhythm, and yeah, so a stroke can occur in any part of the brain affecting any number of functions. So the two main types of strokes is an ischemic stroke or a hemorrhagic stroke. We'll start with ischemic stroke. Um, so an ischemic occlusion contributes to around 85 to 87% of casualties. Ischemia is the inadequate blood supply to an entire organ or part of the body. So in this case, it's the brain. So thrombosis, a thrombotic stroke, the blood flow is affected by the narrowing of vessels due to atherosclerosis. Thrombosis refers to local coagulation or clotting of the blood, and atherosclerosis is the thickening or hardening of arteries. So things like built up plaque in the inner lining, fatty substances, cholesterol, cellular waste products, calcium are all things that contribute to atherosclerosis and identifying that. And then we can have like an embolic stroke, which is caused by decreased blood flow to the brain region, and it causes extreme stress in those tissues and cell death. An embolism is an obstruction of an artery, typically a clot, as it is in this case. So, what this looks like is a disruption of the plasma membrane and then organelle swelling, which then causes leaking of the cellular contents into extracellular space and the loss of neuronal function. So, a cryptogenic stroke typically just refers to a cerebral ischemia of an unknown origin. So, a third of ischemic strokes are cryptogenic. And then we have hemorrhagic strokes. They account for about 10 to 15% of all strokes and has a high mortality rate. So hemorrhaging refers to like lots of blood being leaked out into space. So stress in the brain tissue and internal injury cause blood vessels to rupture. And there's two kind of subproducts to this. So intracerebral hemorrhage is the bleeding within the brain tissue itself, and hypertension tends to be the main reason. And then we have subarachnoid hemorrhage, the rupture of an aneurysm or a head trauma. So subarachnoid refers to the fluid-filled space around the brain, between the arachnoid membrane and pia mater. And there's major blood vessels that pass through this area of the brain. And an aneurysm being a bulging weakened, like this bulging weakness. This bulging causes weakness in the area of the wall of a blood vessel. So high blood pressure, smoking, and excessive alcohol abuse all contribute to this. And a transient ischemic attack is also called a mini stroke, which is just a temporary disruption in the blood supply. It technically infers that you are at a risk for having a more intense stroke somewhere in the near future if you don't make lifestyle changes, which we'll go into. And then you can also have a brainstem stroke, which is a stroke that starts at the brainstem. So here's the pathophysiology of a stroke. You can see here the difference between an ischemic cerebrovascular accident and a hemorrhagic cerebrovascular accident. On the left side, the necrosis is all in black here. You can see where those vessels have kind of died, where there's blockages forming. And with the hemorrhagic, you could see how the vessel has completely exploded. There's an expanding hematoma, which causes a larger area of the brain tissue to die. So, strokes are the second leading cause of death. It is a major contributor to disability worldwide. Strokes used to be classified as a part of the cardiovascular disease, but is now considered a neurological disorder. This can result in motor, sensory, emotional, and cognitive impairments, the extent of which are greatly influenced by the size and the location of the affected area and the presence or absence of collateral blood flow. Nearly 800,000 US residents suffer from a stroke, women having a higher likelihood thereof. So some risk factors, there are more modifiable risk factors than non. So hypertension being the big one, 54% of strokes are affected, of the affected population have this characteristic. Smoking being 15%, drug and alcohol abuse. The relationship follows a curvilinear pattern depending on how much you're abusing, how frequently you're abusing drugs or alcohol. Anyone at any age, at any level of drug or alcohol abuse, it would contribute to having a cerebral vascular accident. Physical inactivity is linked to the other risk factors such as hypertension, hyperlipidemia, obesity, and diabetes. Yep. And so some signs and symptoms of a stroke is this acronym, BFAST. So B standing for balance, noticing balance shifts due to usually the eyes, blurred vision is caused. The face, arms drooping typically is on one side. Speech starts to slur, and that is when it is time to call for an ambulance. So again, even if stroke symptoms disappear, they are a clear warning that a larger stroke may follow. So some treatment, you can manage the risk factors. So despite an enormous amount of research, there are no simple means of treating or preventing clinical causes. So nothing's been really super established. So stroke, acute care, monitoring blood pressure, diabetes, alcohol and drugs, hyperlipidemia. Reperfusion, there's intra-arterial thrombolysis, which combats acute stroke, most effective in the first 6 hours of the onset occlusion. And then intravenous thrombolytics aim to promote fibrinolysis formation, which catalyzes the dissolution of the clot. So IVT efficiency depends on the age of the clot, the specificity of thrombolytic agent for fibrin, and so on. So researchers in the study have found that this drug was effective in reducing a clot diameter in stroke patients within 3 hours of the incident. Rehabilitation, physical therapy, occupational therapy, speech therapy, neurorehabilitation. Since strokes can leave an individual with short-term and long-term disabilities, rehab is used to reinforce functional independency in victims. So sensory, motor, and visual impairments are common, and people usually need a little bit more support with that. We want to increase and maintain as much synaptic plasticity and cognitive function as possible. So with stroke, you'll start to see cognitive decline, which is where drug development, robotics, cortical stimulation, and stem cell therapies will come into play. Stem cell therapy enhances the proliferation of neural stem cells, and it's become a new era of treatment by promoting neurogenesis. So neuroprotection and neurorepair is aimed to rejuvenate damaged tissue and uses stem cell therapy to get the ball rolling, but other clinical trials intend to repair tissue damage and have proven insufficiently effective so far. So, medication considerations, antiplatelets and anticoagulants. Antiplatelets prevent platelets from sticking together, causing like blood thickness. It raises your chances for bleeding though. So if you're a diabetic, you need to be extra careful since wound healing is difficult in these individuals. It inhibits thrombus from formation, allowing for better arterial circulation. And anticoagulants keep blood from clotting. It's an aggressive drug, and it also increases bleeding. So again, for diabetic individuals, this is important to monitor. So stroke victims have some extra contraindication or extra indications sometimes. And they may take other medications for conditions like diabetes, depression, hypertension, or heart conditions. Some medications include ACE inhibitors, beta blockers, calcium channel blockers, and citalopram. So, exercising effects on stroke victims. Exercise has social, psychophysiological, and biological effects. Mood, motivation, frustration, and confusion are specific affective issues. Managing these can favorably influence how an individual conducts, adheres to, and responds to prescribed exercise. So, some strategies to minimize negative influences is close supervision, individualized instruction, involvement of family members, repetition of instructions, and so on. So, cardiovascular disease risk factor reduction is essential since it's all connected. All components of exercise training are important to stroke exercise therapy. So this is a case study of a client that I've actually worked with. So this patient is a 61-year-old male who had a stroke 2 years ago while in the hospital sick with COVID. After a medication intended to treat COVID was administered to him, he suspects it triggered the stroke since he had the stroke in the hospital. His family has no medical history of stroke. The stroke affected the entire right side of his body. His facial muscles are normal, but the right side limbs and all that has been affected. So he can feel his muscles, but muscle recruitment is still limited. The only medication he takes is aspirin and supplements like magnesium. He wakes up at 4 a.m. every day and exercises on a stationary bike and participates in weight training exercise. He is able to complete activities of daily living but struggles with it. This patient does not require medical clearance and would benefit from physical therapy and assisted stretching. The patient's goal is to walk better and faster. He also wants to be able to lift his arm above his head and improve his flexibility. So, due to his stroke, his range of motion has been severely limited. His right shoulder is depressed. The elbow and wrist are constantly flexed. He struggles to swing his right hip forward in normal walking mechanics, and he cannot dorsiflex the foot, which also affects his gait. And these abnormalities affect the mechanics of his left side. His left side is really overcompensating. So the left shoulder is hiked up, the left leg is tight from, again, overcompensating. So some muscular strength tests I would do is bicep curls and a single leg 2-rep max press. And for muscular endurance, I would have him on a cycle ergometer, increase the work rate of 5 to 10 watts per minute and see how he does. And for balance, I would do a single leg stand on firm ground, count the amount of stability mistakes he makes in 3 trials for 30 seconds. So the prescription I would give him and this is per the ACSM guidelines, the frequency I would have him for an anaerobic workout is 3 to 5 times a week, 40% to 70% of his heart rate, max heart rate. The cycle ergometer, I would just have him keep doing that and progressively increase from 20 minutes to 60 minutes a day. And then for muscular strength and endurance, I would have him work out at least 2 days a week on non-consecutive days. This patient already does more than that, but, keeps his intensity at about 50 to 70% of his 1 rep max. And these are some of the exercises I would have him do. Mini squats to help him, reinforce his quads, side lunges to get him mobile on, the sides of his legs, Pilaf press to help move his arms a little bit, as well as tightening the core. Bridges, really important for the glutes and the hamstrings. Um, and dorsiflexion, plantar flexion, inversion, eversion with a resistance band to get that foot mobility moving again, help his gait. Standby assist sidestepping, tricep extensions, internal, external rotations, shoulder rotations with a band, and bicep curls. And then for flexibility, he should be stretching 2 to 3 times a week, if not daily. So just holding to a point of slight tension. So the pulleys really help in different directions because you can use the other arm to kind of pull the other one up. Figure 4 stretch to get his hips a little bit more limber since both sides have been stiffened due to the limited walking mobility and muscle recruitment. The wall ladder would be really good for his arm. Supine cane flexion, trying to get his arm above his head, and passive stretching would be really good for him utilizing PNF. So extra considerations for this patient would be gait and balance training and to avoid the Valsalva maneuver during resistance training and excessive elevations in blood pressure.